This is evaluation and management for beginners or for auditors. This is just my version of evaluation and management, made as simple as I can make it. I am your host and instructor. I'm Dr. Evan Gwilliam. I'm the Executive Vice President of Find a Code, as well as the Chiropractic Institute. And I'm excited to share this training with you because I've worked really hard to make it as practical and as concise as possible. And I hope that you find that when we're done here that you will feel satisfied that you've learned some useful stuff that you've been able to condense and apply in your practices or whatever your role might be in the world of healthcare and E&M coding. First, this is me. I have a background in accounting and business, and I am a chiropractic physician, but I mostly do consulting and expert witness work these days. I have a lot of certifications, and the ones that matter the most for what we're doing here now is that I'm a certified coder as well as a certified professional medical auditor. And I'm going to try to bring that perspective to this. I understand that documenting and coding needs to be practical for the clinician, but I also understand the role that the auditor is going to play. And so I want to bring that perspective to this training for you. So the takeaway is that we're going to try to get familiar with the basics of E&M coding. And then I want you to understand how auditors and coders look at E&M codes, because I want you to figure out how to fit that in with clinicians. And I'm going to speak to you as if you are a clinician, but this is equally applicable no matter what your role is. If you're the auditor or the payer or an office manager, whatever. My goal is for you to understand E&M and know how to apply it in a typical setting. Now, if you're experienced and you're a seasoned veteran with E&M coding, what I share with you may seem a little too basic. However, I've tried hard to kind of come up with a different way to approach it, so you might learn from that particular approach and find some things that you can use in your daily practice. So evaluation management has a little history. It came about first in the early 90s when CMS and the American Medical Association got together and created these codes to use for typical office visits. When the codes came out, there was some confusion about how to apply them. So there was some documentation guidelines that came out in 1995 to help explain and clarify how to document for the codes. But many providers found that they were too vague and too ambiguous, and the terms weren't clearly enough defined. However, it worked fine for general practitioners because, in a nutshell, the 95 documentation guidelines awarded those who examined more of the patient, more parts of the patient. So because of the confusion, they came out with new guidelines in 1997, which were much more specific. In fact, there are many single organ system exams, and each one has a bullet list. And so you're expected to hit those bullets. And what this did is it made it easier for specialists to achieve a high-level exam, because specialists don't examine all the parts of the body. Rather, they will examine one part of the body very thoroughly. So this set of guidelines came about with that in mind. So they work better for specialists, but the 95 still worked better for general practitioners. So at the end of the day, the rule was they're both going to stand. Just use whichever one applies the best to your situation. So in this presentation, I'm really only going to talk to you about the most common evaluation management codes. My goal today is not to teach everything there is to know. It's to teach what 90% of us need to know 90% of the time. So that's going to be my focus. And I know there's going to be lots of exceptions and other circumstances I'm not going to discuss. But that's not the purpose of this training. There are 23 different types of E&M codes. The most common is the office and outpatient services, but there's also E&M codes for hospitals, for nursing homes, for emergency rooms. There's preventative medicine, there's telephone services. So we're focusing on just this one type of service or place of service, the office or outpatient. And you notice there are 10 codes. There's the new patient codes, 5 of those, 5 levels, and 5 levels of established patient E&M codes. The difference between new and established patients is that an established patient hasn't been seen in the same practice by the same professional within the same specialty within the last 3 years. And if the patient has a new injury that they've never had before, or a new insurance policy, that doesn't make any difference. Right? It's just the time frame. Either they've never been in or it's been at least 3 years. Also notice that the fourth character is a 0 for new patients, and it's a 1 for established patients. And then the fifth character, sometimes I'll refer to it as level 1, level 2, level 3, level 4, and level 5. It just makes it a little easier than rattling off all 5 digits every time. So we're going to focus in on these because these are by far the codes most commonly used in healthcare. Now, if you open up a CPT book, you'll see that evaluation management codes have 3 key components and then 4 more contributing factors. And we're going to spend most of this training discussing the 3 key components: history, physical exam, and medical decision-making. However, before we do, I want to take a moment to discuss the nature of the presenting problem, because it sort of has this overarching criteria that we need to meet before we can go into the other things. And at the end of this presentation, we'll discuss briefly time and counseling coordination of care and how those can play in to E&M code selection. But first, I've copied word for word here the nature of the presenting problem from the CPT book, as defined by the American Medical Association. And so the presenting problem is another way to say medical necessity. And I present this to you because I want you to understand that from an auditor standpoint, I don't care how you do with the 3 key components. If I can prove that you didn't have sufficient medical necessity to justify a high-level E&M code, then I'm going to throw out, and I don't care what your 3 key components were. So nature of the presenting problem is somewhat synonymous with medical necessity. And you can see that there are actually 5 different types of presenting problems, and they can be aligned with specific codes to help us understand which codes are appropriate depending on the type of problems that are presented. So a minimal problem is one that's so minor that it doesn't even need a physician to be there. A self-limited or minor problem is one that runs a definite prescribed course. It's not going to permanently alter their health status. The really good prognosis, the patient's going to get better even if you didn't provide care. You're just going to help speed it along, perhaps. Then there's 3 severities. There's the low severity, which is a problem where there's very little risk of morbidity or permanent injury. There's no risk of mortality or death. This patient is expected to recover fully without any functional impairment. A moderate severity problem, there's a big jump because in a moderate severity problem there is somewhat of a risk of morbidity or injury to the patient. And there's a moderate risk of mortality. And I kind of underlined it because to me, that's the big jump. Like if you're performing an evaluation and management service and you believe that the presenting problem has moderate severity, that means that you're saying that your patient has a moderate risk of dying from this problem without any treatment. However, at the end of this description of moderate severity, it does say there's an increased probability of prolonged functional impairment. So that's not quite as serious, in my opinion, but it may help justify this level of severity in other cases. And high severity is where the patient's very likely to have permanent damage or die without treatment, okay, or have severe prolonged functional impairment. So when we go back to the codes themselves, we see that for the new patient E&M codes, this is the way that these were assigned. 99201 is a presenting problem that's self-limited or minor. A 99202 has low to moderate severity, and then we jump up to high when we get down to the high-level codes, which is the level 4 and level 5s. So just keep that in mind, that this is the overarching criteria, and if you don't have a presenting problem that meets the criteria, then you can't do that level of a code. So let's forget about that now and just look at the 3 key components. Let's assume that you did establish medical necessity by establishing that there's a presenting problem that was an appropriate level of severity. Now we're going to dive into the 3 key components, which are the history, the physical exam, and the medical decision-making. Just to give you a brief overview so you understand what these are, the history is the information that is supplied by the patient. So the patient says things, they write things in their intake form, that's the history. The difference is with the exam, that's the information that is supplied by the provider. In other words, the provider gathers the information, does tests, pokes the patient, and learns things, and writes them down or types them in. And that is where the exam information comes from. The medical decision-making is the brain power that combines these other 2 elements, these other 2 components, the history and the exam, and puts them into a plan to decide, how am I going to manage this patient? So these are evaluation management codes. The history and the exam are the evaluation part, and the management part really is the MDM, or the medical decision-making. It's how much work does the doctor or the physician have to put in to deciding what to do and figure out how to diagnose this problem and putting together an appropriate course of care. So the more history you have to take, the more exam that's performed, and the more brain power required, the higher level of code that can be billed. And the rule for new patient E&M codes is that all three of these key components must be met or exceeded in order to qualify for a certain level for the code. So it's 3 of 3 up there you see at the top. Now, if we were to go to the code book, we could see what levels are assigned to these particular codes. And I'm looking at new patient evaluation management codes here. We'll compare to established patient codes in a little bit. So if you look at, for example, a 99202, a level 2 new patient E&M, the history needs to be expanded problem focused, and the exam needs to be expanded problem focused, and the medical decision making should be straightforward. Now that's all lovely, but the problem is most of us don't have any clue what expanded problem focused exam, what that looks like. How's that different from a detailed exam, which is required for a level 3? What's the difference between straightforward and low complexity medical decision making? Well, I don't know based on the words. And so frankly, I'm going to forget about the words. We will come back to them just to refer to them. But this is the official description of the 3 key components for each of the codes for the new patient E&M. But we're going to ignore those and replace them with these numbers. And we're going to break this down to a real granular level because we want to be able to quantify every element required for our E&M code. This is the E&M matrix that I've made up. Okay, you may have seen things like this before. I'll tell you how I made this. I've got a file folder with about a dozen different E&M audit tools in it, some of which I found free online, some of which I paid for through courses or books. And I combined them all to come up with this master document, my E&M matrix. Okay, and there's a similar one for an established patient that we'll compare after we go through a few steps. So you'll notice I still have the codes down the left-hand side, and then as you go across the rows, you're able to find the numbers that apply to the elements for each of these 3 key components. And so you can see that the history is there with its 3+1 elements. In the exam, you have a couple of choices there. The medical decision-making, you got 3 different elements there. So we're going to work our way through this. What we're going to do actually is we're going to audit a record that I made up. We're going to do an audit, and we're going to see what code applies based on, we're going to use this matrix to help us do that. So we're going to begin with the first key component of evaluation management, the history. All right, so what we're going to do is start with our matrix. So here's the matrix, and we can see here in the history, the first element I have listed there is CC, which stands for Chief Complaint. Now, I kind of took a little liberty here. You'll notice that if you go down that column for Chief Complaint, it says Y, meaning yes, for all 5 levels. That's because for new patient, for office outpatient E&M codes, you must have a Chief Complaint. If you don't have one, if the patient says, I'm just here for a checkup, doc, I don't really have anything that I need you to look at specifically, I just want to make sure I'm healthy, do a physical or whatever, then you don't use these codes. Use the preventive medicine codes, which is another category in E&M. But that's not what we're talking about today. We're talking about office and outpatient E&M codes. So you must have a Chief Complaint. So I just kind of threw that Y in there to say, yeah, you got to have it. So what we're going to do is go to a clinical example that I made up. Here's my clinical example. What I have here is the example of the history from a record. So you have a Chief Complaint of neck pain with right arm tingling. And my example, just so you know, is physical medicine, specifically chiropractic, because that's what I am. I'm a chiropractor. But this applies no matter what the specialty is. And this is just an example to help you learn the principle, okay? So the Chief Complaint is easy to identify, right? Here it is. It's neck pain and right arm tingling. That's the Chief Complaint. So it's very readily available. So if I go back to my matrix and I take a look at the Chief Complaint column, I go, well, let's see. If I met the criteria for this, what code can I bill? And if I look at it, I go, gosh, I mean, technically I could bill a 99205, a level 5, based on what I know so far. Of course, I have to go through the rest of the elements on this table, but for now, yes, I have a Chief Complaint, and it looks like I've got a 99205 so far. Okay, and that's what we're going to do. And I encourage you to do this. I want you to follow along with me because I want you to take this matrix and do the exact same thing with one of your E&M visits in whatever your capacity is. You can use the table and forget what you actually build, but look at what the note is and let the note walk you through this. So now we're going to move on to the first real element of history. So chief complaints kind of out of the way, and now there's really 3 elements of history. That's why it says next to history there, it says 3 of 3, because in order to qualify for a certain level here, you must meet or exceed the criteria within all 3 of these elements of history. Chief complaints kind of a given, and then you have these 3 elements, okay? And the first one here is HPI. Now HPI, as you may know, stands for history of present illness. So I'm going to take what's in that column and expand it, because I have in there numbers. Like, let's look back at it for a second. You can see there that for a level 1 or level 2, I need 1 to 3 elements of HPI. But for a level 3, 4, or 5, I need 4 or more. In fact, technically, there's only 2 types of HPI. And when you've done, you go to up to 3, and then when you hit 4, you've reached the next level. So that's something to consider. If you look at your records and you never ever do more than 3 elements of HPI, then you can never bill higher than a 99202, right? So these are the 8 elements of HPI, and I stole all these straight out of the audit tools and out of the CPT book, so I didn't make these up. In the 1997 documentation guidelines, or DGs, we are told that HPI is a chronological description of the development of the patient's present illness from the first sign and or symptom, or from the previous encounter to the present. And these are the 8 things. And the thing I want to point out from this is that I've gone through lots of records. I do a lot of medical record audits with ChiroCode and Find a Code. And the problem is that it's hard to wade through a doctor's note and try to identify what these things are. It takes time. I mean, it can be done, but it just takes time. So in my sample, my clinical example, which I have made it easy to audit, my history of present illness is labeled very nicely in bold. And then there are the 8 items that are identified as elements of the HPI listed in order, underlined so they're easy to find. And then after each one, I've got the information. So this patient was in a car accident and so on, and their pain rate 6 out of 10 and so on. So what you can see here is there's 7 stars, or 7 of these elements I've highlighted. The last one, associated signs and symptoms, wasn't done. That information wasn't gathered from the patient, so I don't get all 8. I get 7 though, because 7 of them were clearly mentioned. And I just want to point out that this is super easy to audit. And if your record has this information, but it's hidden in a complex paragraph and it's just jumbled up in there, it can be audited, but it's harder. And if you make the auditor's job easier and their life simpler, then they're less likely to want to hurt you, I guess. So consider making your records this easy to audit as well, okay? Unless you feel it totally messes up the way that you run your business, but at the same time, I think you should make it easy for the auditor, because we live in a world where there's going to be more and more audits. There's no question about it. So if we know there's 7 elements of HPI, let's go back to our matrix and see what that does for us. We already knew that we had a chief complaint, and that qualified us for a 99205. If we have 7 elements of HPI, that means that we maxed out again, and we're still looking at a 99205 based on what we know so far. Remember, for HPI, I only really needed to hit 4 in order to hit that higher level. So the magic number with HPI is at least 4 elements if it's clinically relevant. Okay, you only do what you need to do for the patient to get them better. And if there's no reason to do 4 or more, then don't do it just to get a higher code. That's, again, where that nature presenting problem comes in, right? It needs to be medically necessary. So that brings us to the next element of history, which is ROS. ROS is an abbreviation that stands for rodents of unusual size. It's one of the 3 dangers of the fire swamp, along with the lightning sand and the flame spurts. And if you ever watch the movie called The Princess Bride, you'll know what I'm talking about. Unfortunately, for this circumstance, we're not talking about rodents of unusual size. We're talking about the review of systems. All right, so here are the systems. There are 14 of them according to the CPT manual. So you might say, well, I group eyes in with ears and stuff. Okay, fine, you can do that. Or I do cardiovascular and respiratory together, or GI and genitourinary together. You can, but the auditor is looking for 14 distinct systems. And so I would encourage you to consider listing them separately with the same headings that you see here, the same headings that I stole right out of the official description for what the systems are for E&M coding. All right. So I did want to show you the one quick example. I pulled this out of a note that I was auditing a few weeks ago. So I looked through the review of systems. They listed all the systems. And for genitourinary, you can read what they wrote here. They said, patient denies burning with urination, urinary frequency, blood and urine, incontinence. Okay, all that's fine. That's all urinary stuff. And then you go on. It says vaginal discharge, vaginal itching. So I assume this must be a female. but it says testicular pain, testicular mass, penile discharge, erection difficulties, and genital sores. So, I'm glad the patient denied both. I mean, there is a condition called, there are hermaphrodites who may potentially be able to suffer from both types of these. But my point is, don't check a bunch of boxes and assume you've done a good job. You better read your notes and make sure that they're logical, because this note, having female genitalia and male genitalia, it looks like the provider is sloppy, and it's going to make me as an auditor look at other things more closely. All right, so just read over your notes and make sure you don't make mistakes like this. So let's go back to my clinical example. You'll notice that I labeled the review systems in the upper right, really nice to see, and I did 4 of them. They're easy to spot. They're all underlined right there, and you can see that these systems were reviewed with the patient. I want to point out this is not the exam. I didn't examine these areas. This is information I gathered from the patient through questioning them or through a form they filled out, okay? It's really easy to do a complete review of systems if you have the patient do a complete form. New patients frequently would do that, and that's totally acceptable. So keep that in mind. Now, I've got 4 here, so let's go back to our matrix and see what that does for our scoring. We already know what's going on with the chief complaint and the HPI, so if we look at the column for ROS, Review of Systems, and I said we had 4 of them, that means that we're going to hit the row that aligns with 99203. Now, I want to point out that for history, we have to meet or exceed all 3 of these elements, for getting the chief complaint, 3 elements of HPI, ROS, and PFSH, which means that my code now can go no higher than a level 3. That's it. A level 3 is as good as it can get for me, because this is an absolute, okay? Now, I want to point out that if I did no review of systems, if you have a practice where you just don't bother ever doing review of systems, you can never bill higher than a level 1. And if you only do 1 review of systems, you can't bill any higher than a level 2, which might just be consistent with the chief complaint. The patient has a musculoskeletal complaint, and all you do is ask them about musculoskeletal issues. Then you could do that, count that as a review of systems. But if you never ask about anything else, you never can bill higher than level 2. And you may be missing out because medical necessity may say, you know what, you should really check out the nervous system and ask them about bowel and bladder and look at their skin and so on, or ask them about those things. And so it's easy to perform this, but only when it's clinically relevant, okay? So that brings us to the final element of history, which is PFSH, all right? Now, PFSH, this is kind of abbreviated, but it stands for Past Family and Social History, and I've listed some of the elements here. Now, the way that this one works is there's only a maximum of 3, you can count 3 elements max. So let's say that I look at past history and I did all of those things. I did 5 of them. And there's actually more than what I'm showing you on the screen here. I don't get to count 5 elements. That all counts only once as past history. Okay, so there's a maximum of 3, and you get at least 1 in each of these, and you can get 3. So we're going to look at my note and see what we did here in my clinical example. You can see very clearly on the right-hand side, I labeled past history and family history. So I didn't do social history. That's okay, no big deal. I mean, I didn't do it. I could have, and it probably would have been clinically relevant in this case, but I didn't. So if you take a look at the past history, I asked about 3 different things there. I got information about medications and an old hospitalization and old treatment. So that counts as 1, okay, counts as past history, even though there's 3. And then in family history, there's 1 thing there about some diabetes, so that counts as another 1. So this actually counts as 2. I do want to point out to you that under past history, I stated that he was treated at this clinic for low back pain in 2014. So technically, this is an established patient, but we're going to look at him as if it's both, okay? So ignore that statement when I'm analyzing this for a new patient, and then we'll pretend that counts when I'm looking at an established patient, okay? But we're going to start with this patient as if he was new. So if we go back to our matrix, again, we already have established the chief complaint, the HPI, and ROS. Now we look at if we had 2 elements of PFSH, that means that we're in that same row along with the ROS, so we're definitely at a 99203. Now, note that if I had simply found justified to ask about social history, I would have gotten the 3rd element there, and that would have qualified, at least for that column, all the way down to a level 5, but it still would have been limited by the review systems. The review systems has to get to at least 10 before the history will qualify for a level 5. Okay, so I mentioned that we had words to describe these codes to talk about what level of history this is. This is actually a detailed history, but I had replaced it with the numbers because numbers are quantifiable, right? I like numbers. But let's take the numbers away for a moment and look at this as if I just had the words again. So I'm back just looking at the description in the CPT book, and it says that a 99203 has a detailed history. And that's what I had determined from my case. But in order to figure it out, I really needed to use the numbers and to quantify it. So this is a 99203 because it has a detailed history, depending on what we find for the exam and the medical decision making, the other two key components. Okay? Now, this is the new patient E&M. Let's say that this was an established patient E&M. If we were to open up the code book and switch this over to the established patient evaluation management codes, which are now listed on the left-hand side, the descriptions in the boxes here, they shift. And if I had a detailed history now, it actually qualifies for a level 4 for an established patient. One thing I need to point out with the established is you'll notice at the top it says 2 of 3. Main difference between established and new patients is that established patients, you only have to meet 2 of the 3 key components, meet or exceed. So right now, it looks like I have a level 4. It really depends on what happens in the other 2, but I only have to get one of the other 2 at least to this level. So that's what I'm kind of looking for. Notice that the descriptions here, the words shifted down a little bit, and the 99201 is a little different. It doesn't actually have 3 key components, but I threw some words in there to help you understand what might qualify for that. We'll discuss that briefly, possibly a little later. So if I replace those words with numbers, this is the established patient E&M matrix. It's different from the new patient. It's similar. I have different codes down the side, and I have numbers all throughout, but the numbers are shifted downward for the most part because there are no criteria for 99211, really, and the criteria is different for others. So if I were to drop in the same criteria we just found for that patient, but call this an established patient, you can see that everything but the ROS qualifies for a level 4. Again, so this is a detailed history, and it qualifies for a level 4 established E&M, but a level 3 new patient E&M. All right. So what we're going to do now is we're going to go through the other 2 key components, the exam and the medical decision making. We'll look at it as if it's a new patient, and then we'll compare it to the established patient matrix. And we'll go through this until at the end we can decide for sure what code we're going to assign to this case. So we are now on to the exam, the physical examination portion of the evaluation management. This is the second key component. So as we look at our matrix, there's the exam. You'll notice under exam, I've created 2 columns here. So we need to look at these. The first column is the 95 DGs, or the 1995 documentation guidelines that were released by CMS. So what we're going to do for this case is we're first going to evaluate it based on the 95 DGs, and then we'll evaluate it based on 97. The thing that's unique about these columns is that it's either or. I don't need to worry about both of them. I need to pick the one that seems to work the best for my case. And whichever one that is, that's what I'm going to use. Okay. So we're going to start with the 95 DGs. There used to be some differences with the history with the 95, 97 DGs that were more marked, but they've tweaked that now. And the main difference I want to emphasize here is the exam information. So according to the 1995 documentation guidelines, you can count either organ systems or body areas to meet the criteria that was in my matrix there. So I'm a fan of organ systems, especially for physical medicine, which is what I do, because it's really easy to hit at least 2 of these, which kind of gets you to a certain level for most patients in a physical medicine setting. But you might find that body areas makes more sense. The rule here is if I count, let's say I count abdomen as a body area, I can't also count gastrointestinal as an organ system because those overlap. So I have to kind of go either or, okay? And for my example, we're going to look at it as organ systems just because it fits the way I set it up. So here's an exam. Here's an exam for a patient. You can see I've done some vital signs at the top. There's a description of some cardiovascular findings, some musculoskeletal findings, and some neurological findings that were conducted during this exam. So if we take a look at it, we've got at the top the constitutional or the vital signs, and then we have the other 3 that I've labeled very nicely here. So what we're going to do is we go, okay, we got 4 organ systems here. Let's take it back to our matrix and see what that does for us. We go back to our new patient E&M matrix, and for the 1995 documentation guidelines, I'm going to say that that qualifies as 2x to 7x. Now, I need to explain to you what the x means, because this is where the 95 guidelines are fairly vague and they leave room for interpretation. You'll notice that for level 2, on the 95 guidelines, I need 2 to 7 organ systems or body areas. But for level 3, I need 2x to 7x. The x stands for expanded. It means that I'm examining at least 2 different organ systems or body areas, but one of them, the one relevant to the chief complaint, I'm looking at much more thoroughly. So the difference would be if I only looked at 2 systems lightly, or anywhere from 2 to 7 lightly, I would get a 99202. But if I look at least one of those systems much more thoroughly, then I qualify for an expanded exam, and that bumps me up a level, in this case to a level 3. So just based on the exam alone, based on what we've done so far, this looks like a level 3. Of course, we have to combine that with the history and the medical decision-making to determine if that's correct. But that's where we're at this point in time. Now, when we're looking at the exam, we also need to consider what would happen if I used the 1997 documentation guidelines. So now we're going to go down this column, and you'll notice this one's a little different. It says 1 to 5, 6 to 11, and then it has 12 in 2 and 18 in 9. This one is much more specific. Instead of organ systems or body areas, this is bullets from a list of the specialty or the specific examinations found in the 1997 documentation guidelines. And what I've done is I pulled a couple of pieces out of the general multi-system exam. So there are 14 system or body areas for this exam, but I'm only showing 4 here, 2 on this slide and 2 on the next slide, because they're the ones that apply to this case. I just felt like it would take too long to show you all 4 pages of the general multi-system exam from the 1997 documentation guidelines. But this works pretty well for many general practitioners if you want to use the 97 guidelines. Let me show you how it works out in my case, okay? You'll notice that the first body system area is constitutional, and you can see there's vital signs. And if you recall, in my record, I did 3 of these, and it says I have to do at least 3. So I did that. I didn't do the next bullet, though. So if we go down to cardiovascular, if you were to look at my record, you'd see that I made a statement about analyzing the patient's pulse, and I also made a statement about swelling. So I qualify for 2 more. So I get to count 3 bullets so far, okay, using these 97 guidelines for the general multi-system exam. And then we move on to 2 more body systems or areas in this general multi-system exam from the 1997 DGs. And if you look through my record, you'll see that I only examined 1 area. The paragraph kind of in the middle of your screen there talks about the 6 areas that you can examine. And you can, using this criteria, if you did all 6 of those areas, you got 4 bullets. So you could do 6 times 4 and get 24 bullets. But I only did 1 area, so I can get a maximum of 4 bullets for that area. And you read my note, you see I did palpation, I did range of motion on this patient's neck, and I did muscle spasms. So I get 3 more bullets for the musculoskeletal system. And then I also did a little bit of neurologic testing. I did some deep tendon reflexes because the patient complained of numbness. And then I did some pinwheel testing for the same reason. And so I just gained 2 more bullets. So that means I have a total of, I forget, was that 7, 8, 9, somewhere in there. I'll show you when we get back to the matrix. Let me show you where I got those from in my note. I'm using the 97 guidelines now. Here's my vital signs, right? Here's the cardiovascular, the swelling, and then the pulses. That got me 2 more bullets. In the musculoskeletal, there's my palpation and my range of motion and my muscle spasms. So there's 3 more bullets. And the neurological, I've got my reflexes and the pinwheel testing. So I had 8 total. So I'm going to go back to my matrix now. And we're going to go down that 97 column, and we'll say 8 bullets is going to get me how much it's going to qualify for 99202. Well, if I had simply gotten to 12 bullets in at least 2 different organ systems, I would have qualified for level 3, but I didn't. I only found 8 bullets. So I don't have to count this because, as you recall, the 95 documentation guidelines gave me better results. And since I got better results, I'm going to use those better results, and I'm going to go back down to my level 3, and I'm going to ignore the 97 for this example. But we are permitted to use whichever one works better, okay? I should point out that the 97 guidelines also have a slight difference with the history in that if you are analyzing 3 or more chronic conditions, then you bump up to the higher level of HPI as well. So I forgot to mention that, and I couldn't fit it into my matrix. So let's back up here and remind ourselves, what did we find with the history? Well, we found, chief complaint, HPI made it all the way down to the bottom, but the ROS and PFSH was limited to a level 3. So it looks like everything is lining up for a level 3, but we need to find out what's going on with the medical decision-making still. Before we do, let's get rid of these numbers and replace it again with the words from the official code descriptions. And we see now that what we found is that we have a detailed history and a detailed exam. we now know how to quantify what these words mean because we can use the matrix to fill in the blanks for us. All right, and a detailed history and detailed exam lines up with a level 3 new patient E&M. We need to figure out what's going on with the medical decision-making now because we need to meet or exceed all 3 of the 3 key components. And if a medical decision-making is only straightforward, this is level 2. If it's at least low, then I'm a level 3. If it's moderate or high, I'm still a level 3, okay, because I'm limited by whichever one of these is supporting the lowest level. Now, let's take a second and look at this as if this were an established patient again. We simply swap out our matrix now with the one that shows the wording for an established patient, and you can see that since I determined I had a detailed history and a detailed exam, it's a level 4 established E&M code, okay? And in this case, I only have to meet 2 of the 3 key components, so frankly, I don't care what the MDM is. The medical decision-making could be straightforward, it could be high, it doesn't matter. I'm going to get a level 4 for this one, okay? But we'll look at it anyway. Before we do, here's how it comes out in the established patient E&M matrix for the numbers without the words, right? There's the history, plugging in the exact same numbers we've already found. And I'm going to use my 95 EGs here again. And again, it shows level 4. All right, so everything is hunky-dory. Now we're going to go on to the final and third key component of evaluation and management, and that is medical decision-making. Okay, and medical decision-making, again, is the brain power. It's bringing together all the information that was gathered from the history and the exam. It's the management part of an evaluation and management code. You'll notice that next to medical decision-making, we've got 2 of 3. What that means is for the 3 elements here, which is diagnosis, data, and risk, you only have to meet or exceed 3 of those criteria in order to qualify for a certain level. So, for a certain type of medical decision-making, I should say. So for this one, what I'm going to do is I'm going to take these 3 columns, and I'm going to expand it into a bigger table so we can look more closely at this, okay? So we'll come back and plug in the numbers here, but the medical decision-making really looks like this. We have these 3 columns on the left, and then the one on the right, the final column, is the type of medical decision-making. And what we need to do is combine the 3 elements here, the diagnosis, data, and risk. We combine those 3 to determine what the type of medical decision-making is that's on the far right. Okay, and we're going to begin with diagnoses. You'll notice there are 4 different levels here, and I've got numbers there too because we can assign points to this using the audit criteria that's been established by Medicare and other sources. So now what we're going to do is take that diagnosis column and we're going to expand that and figure out how do we determine what the difference is between a minimal, unlimited, and multiple and extensive number of diagnoses or management options is. How do we get these points? Well, it's based on this criteria. If the patient has lots of problems, lots of diagnoses to manage, then you get more points. And if they have fewer problems and they're established problems, then you get fewer points. So you can see here, for example, you get 2 points if you have an established worsening problem. You get 3 points, however, if it's a new problem and there's no additional workup, meaning you're not waiting on some other facility to return blood work or imaging to determine what's going on. And you notice that a couple of these have some little criteria where it says max 2 at the top for self-limited or minor problems and max 1 for new problems, no additional workup. Also, I want to point out that if you were to find in your documentation the words stable or improved or worsening, new and established, that's great because that makes it super easy to audit. An auditor otherwise has to go through the record and try to figure out what it means and interpret it, and you don't want them to interpret it wrong, so you should make your records match this as best you can. So what we're looking for here is how many problems does this patient have? How much has to be managed here? And if you go to our clinical example, I've written up an assessment and a plan for this patient. The assessment says that they've sprained their neck and they have some radiculopathy, okay? So we have their problem. They have a new problem. The question is there additional workup? And if you read through my plan, you see what we did a Davis X-ray series, which is a 7-view X-ray series, 72052. And there's a separate report for that. And then it says the initial treatment is we're going to see this patient to do some rehab and chiropractic manipulation. And then we're going to do some exercises. And we're going to reassess them after a period of just 2 weeks because we want to see if they need an MRI due to this numbness, if there may be some disc injury, right? So you look at that and go, well, gosh, additional workup. Yeah, you did X-ray and an MRI. Well, the truth is the x-ray was done right then and there. So it doesn't count for this part of the scoring because I'm not waiting for the results to come back. There's no additional workup. It's part of the workup I'm doing right there. And the MRI, you'll notice it says consider MRI. I'm not ordering it yet. I'm not waiting for it. So I can count that as additional workup later on if I do an E&M when I decide to order that MRI. So those don't actually fall into the consideration for number of diagnoses or management options. And as we look at this, what we determine is we got a new problem with no additional workup, so I get 3 points. All right, that's how this comes out. I get 3 points. So we're going to take this back to the first column in our medical decision-making table, and we see that for number of diagnoses or management options, I got 3 points, which means it's multiple. All right, and if you were to work your way across to the far right, you'd see that qualifies for a moderate complexity type of medical decision-making. But that really depends on what we find for data and risk. We need to look at those two, and then we're going to count the two best ones and see how that lines up on the far right, okay? So the first thing we looked at was how many problems does a patient have? How many diagnoses, how many conditions are we looking at? The second column here that we need to look at is data. This is the amount and or complexity of data reviewed. And the issue here is how much stuff do I have to look at? How much brain power do I have to use to analyze? Are there 3 other reports from other providers? Is there an MRI? Is there blood work? Do I have a lot of data to consider here? And if I do, I get more points. So we're combining the number of problems a patient has with the amount of data, and then the risk will be the third one. And we combine those 3 again to get our type of medical decision-making. So let's take this column data and expand it and see what we can do and how we determine what these points are. Because I can see there are 4 different levels there, but I don't really know how they work. So I open up the table and I can see here how to get points for this. It turns out if you order tests from different sections, you can get a point. If you need to discuss test results with the performing physician, so you need to speak with the MRI, the radiologist, you get a point for that. If you decide to get some old records or history from someone other than the patient, perhaps the patient can't speak on their own and you need to speak to one of their family members, you get a point for that because that takes more time. If you review old records and you write up a summary, then you get 2 points. And if you feel like you need to read the MRI yourself or the lab results yourself because they did a lousy job, then you get another 2 points. So let's go back to our clinical example and see what we did. The data that we gathered was we ordered an x-ray, all right? We did this 7-view x-ray series on this patient because of their neck injury. So remember, we want to do the MRI too, but it doesn't count because we didn't actually do it yet. So if we go back here, what that turns out in this table for the amount and complexity of data is that we did a radiology code. We did 72052, and that gets us a point. And that's it. We didn't do anything else on here. So we only got 1 point for this one. We're going to take this back to our medical decision-making table, right? We already knew the diagnosis. So we got 3 points there. For data, we got 0 to 1 point. And it means it's minimal. There's a minimal amount of extra data we need to consider for this case. So that doesn't justify a high-level E&M code on its own. But combined with other things, we'll see how it works out. The final and third element of medical decision-making is the risk. And you can see that there are 4 types of risk, 4 levels there. And, I don't know about you, but just looking at that, I would have one opinion of what's low and someone else could have a different opinion of what's moderate. So we need some standards. So we have one. And this is the official table of risk straight out of the 1997 documentation guidelines. You'll see there are 3 columns here. On the left, instead of on mine, so on the left, you can determine the level of risk. And the way that you do it is you go through the 3 columns: presenting problem, diagnostic procedures ordered, and management options selected. And you look for one that aligns with what you're doing, and you can pick the one that's the best. So if I get way down to the bottom of this table, then I can go over and select a high level of risk. Right? So it doesn't matter if all of them are up high, but one is down low. The one down low is the one that dictates. So this table is the official table, and the problem I have with it is that it doesn't apply to all specialties. Like if you look at it, some of the stuff you may never ever see. And so for other specialties, you may be able to find your specialty association may have worked something out for you that's more specific to your specialty. And so I've done that for this example because it's chiropractic. You can see that I've made an unofficial chiropractic table of risk. And my disclaimer is this won't stand up in court or in scrutiny. You can't use this. It's just an example that I came up with as a chiropractor to help my chiropractic clients to understand better how it would line up for them. So I took a lot of the same information right out of that table, but I added some of my own that fits with the chiropractic specialty. And you notice I only got 2 columns here. But we go back to our clinical example, and we'll compare it to the official table of risk and my unofficial table, right? You'll notice here that I've got a patient with sprain, and I also have prescribed exercises for this patient. So if you go back to the official table of risk, you can find that sprain and physical therapy align with a low level of risk. There's nothing else in my note that gets any higher for the level of risk. And if you were to look at my chiropractic unofficial table of risk, I've done the same thing. I've included the words in there. So it lines up with low, and it's just a little easier to understand for those who are unfamiliar with that big, ugly table with all of its other examples in it. So we take this information back to our medical decision-making table. We've already established the diagnosis and data columns. Now we got risk, and we just figured out it was low. So because the risk was considered low, that's going to become my limiting factor here, because as you recall, for this table of these three elements, I only have to meet or exceed two of the three. And so as we go to look at the type of medical decision-making here in our final column, as we line this up, we can ignore the one that is the least contributory, okay, which is the data column. That one doesn't count. The one that limits this is risk. And if risk got up to moderate, the whole thing would be moderate, right? Or if data got up to moderate, the whole thing would be moderate, and I would ignore the risk column or whatever. So this is a low complexity type of medical decision making. We're going to take this back to our big matrix now. So we move away from that detailed table, and now you can see I have the numbers plugged in here for medical decision making. You see that we got 3 points for data, 3 points for the diagnoses, 1 point for data, and we had a low level of risk. Now, because I only need to meet two of the three elements here, I can ignore the one that's the lowest, and I'm limited by the next lowest, which is the one that lines up with the 99203, which is okay with me because my history and my exam also lined up with a level 3 new patient E&M code. And so we can see with great confidence that this case, if we audited it correctly, is definitely a level 3 new patient E&M. Now let's drop the matrix for a minute and go back to the official words from the code book. That means that this case is a detailed history, a detailed exam, and a low complexity medical decision making. Again, if the medical decision making was straightforward, this whole thing would become a 99202. If the history was only expanded problem focused, the whole thing would become a 99202. You're limited by the one that contributes the least, okay? So this is a level 3 because everything lines up quite nicely. But what if this were an established patient? Again, let's go back to the established patient example. We're looking up the established patient codes in the CPT book, and it tells us if you have a detailed history and a detailed exam and a low complexity medical decision making, then you get to disregard the component that contributes the least to my code, and I don't have to worry about medical decision making in this case. And I can stick with my level 4, even though the medical decision making lined up more with a level 3, because that's the rule for established patients. Okay, so let's look at this as if it was in the matrix with the numbers, right? We replace the words with the numbers, and we drop them all in here. Now, remember, I only have to count 2 of the 3, and since medical decision making is the lowest, it doesn't contribute as much, I can ignore those, and everything lines up with a level 4 established patient E&M. So that's how the key components fit, and that's how they work to help us see how this all comes together. Now, we're going to move away from the 3 key components here as we wrap this up, and we're going to talk about an exception, which is the time override. Okay, but before I get into it, I want to remind you those matrices that you've seen, the established and the new patient matrices, you can use those in your clinics today. I mean, go back and look at the last E&M code that you did and evaluate it and use this criteria I just taught you and audit your codes and see if you did it right. Okay, I'm hoping that what I've shared with you makes your life simpler. It makes it easier for you to audit, and also consider how you can improve documentation to make it easier to audit. Now, time is a special circumstance because the rule is if counseling and or coordination of care, which are contributing factors to E&M code selection but not key components, if they contribute more than 50% of the time to the encounter, then time becomes the key controlling factor. And what that means is we throw out the 3 key components. They don't apply anymore. It's time that you use to select the code. And we are told in the CPT manual what time is appropriate for which codes. So you can see, for example, that a 99214 requires a total time of 25 minutes. And if over half of that time was spent counseling and coordination of care, then that would be the right code, regardless of the 3 key components. Likewise, if I spent 30 minutes with a patient, a new patient, and I spent more than 15 of those minutes counseling and in coordination of care instead of the 3 key components, then I could bill a 99203, okay? So when you go to the CPT manual, in the E&M, the green pages that tell us the E&M rules, we are told that counseling typically includes these 7 things. And counseling would be discussion with the patient and or family. You have your diagnostic results, impressions, and or recommended diagnostic studies, the prognosis, the risks and benefits of management options, instructions for management and follow-up, importance of compliance with chosen management options, risk factor reduction, and then patient and family education. And what we're told is that a counseling session could include these elements. It doesn't have to include them all. So here's what I would suggest you do when you know that you're going to be using the time override. Consider creating a form that records the time and lists the 7 counseling items as subheadings. And then you can simply fill it in. Now, if you did a paper record, you would just have those 7 subheadings, and whichever one's applied for the time that you spent with the patient, you would just fill in the blanks. And then you could show that to a coder and auditor, and they'd see exactly what they're looking for. Let me give you an example, because I've done one. I've got a note here that's labeled Evaluation and Management Counseling Record. Like, I even called it counseling. And then I said the following information was discussed with the patient. And then in bold down the left, I've got the 7 items that are considered counseling, which is appropriate for the time override. And then you can read through this, but basically I documented what I've discussed with the patient for each of these 7 elements of counseling. And at the bottom, I listed the time. So I said, look, I began this counseling, this encounter at 3:40 p.m. and it ended at 3:58 p.m., which is 18 minutes total, right? But I documented that I spent 16 minutes face-to-face with the patient during this 18-minute encounter. And I was talking about these things. I didn't spend the time doing an exam or gathering history. It was counseling them and explaining to them what was going on here. And I documented all this stuff. So I hand this record over to the auditor, who says, why'd you build that code? You didn't meet the 3 key components. I said, because I'd used the time override. And I can look it up and discover that if this was an established patient, an 18-minute encounter where 16 minutes was spent face-to-face easily justifies a 99213. If that encounter had been 25 minutes total and I'd spent 16 minutes face-to-face at a minimum, then I would have qualified for a level 4. But in this case, it's definitely a level 3. And that is how you do the time override, right? That's how you apply that concept. So what we've just done for the past almost hour is we went through the basics of evaluation management coding, kind of talking about nature presenting problem and then the 3 key components and then the time override. I hope that based on this education and this discussion, you understand how auditors and coders look at E&M codes. You know what criteria they're looking for, and I showed you how to quantify it by using these matrices. And if you can do the same thing within your clinic, or if you're an auditor and you want to use this to audit more easily, that's great. I just hope that the records we're looking at match up nicely so that it's easy for everyone to get along and we can all be friends. All right. So it's been a pleasure teaching you this information. I hope that you have found it to be as helpful as, well, if you've enjoyed it as much as I have teaching it to you. There are further resources, and there's all kinds of other exceptions. We didn't talk about the other types of E&M codes. We didn't talk about the use of modifiers and E&M code distribution and different specialties and whatnot. There will be resources for you available at Find a Code and ChiroCode, and we want to help you. So please go and look for those resources, contact our customer support, and we'll help you become experts on all things E&M. But my hope is that this presentation helped you solve the problem so that you know what to do 90% of the time with 90% of the encounters. Thank you so much for being here with me.